Thanks for giving us clarity on immunomodulation, which has always been a controversial topic when you're dealing with management of sepsis. So now coming to everybody's favorite topic, artificial intelligence. So how can artificial intelligence be leveraged to analyze and predict the long-term mortality risk among sepsis survivors based on patient characteristics and specific factors observed during initial critical care admission?
Right. So I'm not an AI expert. I'm going to kind of say that. The only claim I can make is I did a master's in epidemiology at the London School. So that's the only bit of thing that I'll claim as the reason why I can say something about AI. So your question is, can you use AI to predict long-term risk? So any prediction tool requires an independent association between that variable and the outcome in question. And I'm going to talk about one tool that I was involved in developing, which is based on, it didn't use any artificial intelligence. It just used normal intelligence and regression model. So what that tool is it asks the question, can we use sepsis characteristics of patients when they come into ICU to predict what happens to them longer term? So what we did was to do a regression model, and using that regression model we said we can derive a prognostic score that tells you the risk of developing a longer term outcome like rehospitalization or death by 1 year. So now coming to the AI question. Most of the under the bonnet AI activity or machine learning activity is to look for association between the exposure and the outcome, and often involves multi-level modeling of some description to come up with a score or a prompt or a nudge or a trigger or whatever it is. So I think majority of the outcome exposure relationship is predictable based on the data that we have using simple regression models. What AI can probably do is to make that automation, probably make that validation of the data quicker, and make the recalibration of the data for different geographic areas or different variables quicker. I mean, that's the best I could answer, because I'm not an AI expert, and I don't want to kind of say things that I'm not an expert in. But that's the best I could do.
Thank you, Professor Manu Shankar Hari. If you could ask me, how will I conclude your podcast? Our podcast is that the questions have been answered in a way from a scientist level to the clinician levels. That is what the viewers and listeners would love to hear. So once again, it's a real honor to have you here, and thank you so much for joining us.
No, thank you so much for having me.
Yeah. Before I conclude, let me ask you one more open question. So yes. What, as an expert in the field, would you like to share with your listeners, especially with regards to the work, the research work you are doing right now with vaccines for immune recovery following sepsis?
I think, to me, it feels like, at least intellectually, I feel that we are still trying to cling on to slightly outdated ideas and eminence-based medicine. I feel like there is an opportunity with the advances in molecular biology, genetics, the computational points that you guys highlight. The goal of all of us should be to kind of probably work together with very different specialities coming together to actually produce something much more unique for sepsis. I think that is what we try to do with that Lancet Respiratory Medicine paper on immunomodulation, because we felt like we're just talking to critical care folk and we're not talking to people outside. That's one. And the second thing that I want to say about the sepsis survivor question that you specifically kind of highlight, To me, currently, what we are doing for sepsis survivors is totally disjointed. We know that sepsis survivors have got broadly few domains of disability or ill health, which is they got physical and functional disability, they got cognitive and mental impairment, they got kind of impairment in things like swallow, and their comorbid conditions are thought to worsen, and they got a risk of adverse long-term outcome. And if you're really thinking about what a patient is actually looking at you for a doctor, they're not looking for fancy new things. They want to understand, can you do anything for the new functional limitations that I have? Can you do anything for my cognitive impairment? Like 1 in 3 sepsis survivors have anxiety, depression, or post-traumatic stress disorder. They are asking us, can you actually follow me up and do something specific for that problem, rather than giving me kind of things like fancy treatments? They are asking us, often sepsis survivors who have adverse outcomes come from poorer background, and they are asking us, actually, when I actually have a long-term problem, I am unable to actually go and look for solutions because my income that I get, I'm going to use to eat food or look after my family, rather than going to look after myself by going to a clinic or giving the doctor some money to make me better. And I think the disparities are so much. It's not just a lower and middle income country problem. It is a problem across the globe. We just aren't really saying. There is a King's Fund report that highlights the same problem in a different context in England. There is a WHO report that highlights just disparities. When you survive a critical illness, you lose your income more or less overnight if you're a young person, or you get so frail that your activities of daily living are gone and your cognitive function is impaired. I mean, if you are really trying to do something to help sepsis survivors, those are the things that we need to focus on at a kind of policy level, rather than trying to give them, I don't know, Smarties in the hope that they'll feel better. That'll be what I would say to people.
Perfect answer. I think that was an not in the list question, but thank you so much for answering.
That's a good way to conclude the podcast, I feel.
Thank you.
Recording can be stopped, Chirag. Chirag, you can stop.